This is a patient with a cataract and 360-degree occlusal pupillae, secondary to past history of acute angle closure glaucoma, secondary to severe iritis, then develop this 360-degree of seclusio pupillae and angle closure glaucoma. So all that has been resolved, and now is the surgery to improve the vision. After the initial incision, intracameral lignocaine is injected because there is a lot of manipulation of the iris tissue, and this is followed by tamponating the anterior chamber and protect the cornea with a viscoelastic. And then a coupling hook is then used to separate the adhesion between the iris and the anterior capsule in a careful manner. So sometimes you can also use two coupling hooks in order to separate this adhesion. In this particular case, I'm just using one coupling hook. As you can see now, the pupil is much better than earlier. And again, this is a full-length video with 2 times the original speed. And now after breaking up the adhesion, I will inject a bit more viscoelastic. I'm injecting some adrenaline into the anterior chamber right now in order to assist in enlarging the pupil. And also I'll inject more viscoelastic into the anterior chamber to widen the pupil as well. Then anterior capsulotomy is performed with a capsulorhexis forceps in the usual manner. In this case, I try to enlarge the rhexis to about 5 millimeter, so it's actually done beyond the pupillary margin. Then this is followed by a hydrodissection. As you can see here also, the nucleus is actually not very dense, so this helps in performing the cataract surgery. So after the hydrodissection, the phacoemulsification begin, and first I will remove the soft cortex, and then I make the straight trench. So I usually will use to perform this stop and chop method. So once I get to the desired depth, a second instrument is then used to assist in cracking the nucleus into half, and then the nucleus is removed in a chopping manner, bit by bit, as you can see shown in this video. So as you can see, the nucleus is not very hard, so it's not that easy to hold the nucleus, but what you can do is to rotate the nucleus so that you can still hold the nucleus whenever possible, pull it to the center, and then emulsify it in a safe manner. So I'm mobilizing the part of the nucleus that is not accessible easily to a position where I can access it easier to vacuum it and try to bring it to the center. So in a gradual fashion, once I find that the viscoelastic is insufficient in the anterior chamber, I'll put more viscoelastic, or in this case actually I find that I have actually managed to remove most of the nucleus, and so the soft epinucleus and cortex is being aspirated with an IA instrument. So as you can see, the nucleus and then the epinucleus both safely removed. So I'm trying to aspirate as much cortex as possible from the equator of the corp capsule. So once I'm satisfied with the aspiration, I'll fill the anterior chamber with and the back with the viscoelastic again, and using a Kugeln hook to do some inspection to see whether there is any large chunk of cortex that I left behind. When I'm happy with this, the aspiration, then I'm going to load the lens. In this case, my staff actually trying to help me to load the lens initially, but unable to do it properly, so I have to do it myself. This is an eye that I'm implanting the Envista toric because the patient has quite a high corneal astigmatism as well. As you can see, I already pre-marked the cornea. So as you can see also the axis of the lens. I have not positioned the lens in the correct axis yet. So I would first remove the viscoelastic both anteriorly to the lens as well as posterior to the lens, which I'll show later. So before I aspirate remove the viscoelastic from the back part of the lens, I secure the wound first. I push the optic away, lift the optic up, and then flush the back part of the optics in order to remove the viscoelastic. So now again I deepen the anterior chamber with the VSS, and at the same time I will try to mobilize and move the lens to the position that I want the axis to be. Now of course this is a case where it's difficult to see the indicator on the lens, so I have to use a Kugeln hook to have a look where is the axis, and then have to, if the axis still not correct, I'll have to get into the eye again using a 27G cannula, inflating the anterior chamber and adjust the axis at the same time. Again, a Kugeln hook is used to identify, to check the axis, and also a Kugeln hook is used to rotate the lens further in order to make sure the axis is in the correct position. Again, I double check again, and once I'm satisfied with the axis, I secure the side port incision, and then I'll check again, right? So I think I'm satisfied with the axis, and I'll secure the wound and check the wound, make sure it's not leaking, and that's it for the surgery.